Good evening, ladies and gentlemen. The event will begin momentarily. Please make sure to check the interpretation button at the bottom of the screen. If you'd like to listen to the webinar in Arabic, you'll just need to click on that, select Arabic, and select the mute original option. You'll be able to enjoy this event in Arabic. Well, welcome everybody, and thank you for joining us today. It's our pleasure to welcome you to today's World Heart Day webinar, coinciding with World Heart Day. My name is Lama Zala, and on behalf of Cleveland Clinic Abu Dhabi, I would like to extend a very warm welcome to all of you, and thank you for taking the time to join us today. Today is World Heart Day, and in recognition of this day, we have world-renowned cardiologists, Dr. Hani Sabur and Dr. Rani Shantouf. They're from Cleveland Clinic's Abu Dhabi Heart and Vascular Institute, and they'll be exploring with us today the risks of heart disease, which is one of the most serious leading causes of death in the UAE, and why is it affecting more young people than it ever has before. We'll be talking about the risks, what are some of the factors, and what you can do to make sure that you manage your heart health. Some of the topics that we're going to be discussing today are quite it's a variety of topics. We're going to be talking about the early onset of heart disease and why it's happening. We'll be talking about the high burden of risk factors for a young age and how common things that many of us do, such as smoking or not watching our cholesterol, or perhaps obesity and diabetes, may impact your heart health in ways that you didn't know. The discussion is going to be followed by live Q&A, so please stay tuned towards the very end because you as the audience will have the opportunity to ask our doctors any questions you may have about your own heart health. And it would give me great pleasure now to introduce our own doctors that we have with us today. We'll start with Dr. Rani Shantouf. Dr. Rani is one of our staff physicians at the Heart and Vascular Institute at Cleveland Clinic, Abu Dhabi. And Dr. Rani, he received his medical degree from the University of California in Los Angeles, commonly known as UCLA, where he completed his residency in internal medicine, followed by his cardiology fellowship at the Harbor UCLA Medical Center and the interventional cardiology fellowship at the University of Southern California. Dr. Rani is an educator at heart. He has done quite a few educational elements throughout his history. He has worked at UCLA as the director of the Cardiac Catheterization Lab of Olive UCLA Medical Center and has been involved in teaching as he was the health sciences assistant clinical professor of medicine at the David Geffen School of Medicine at UCLA. Dr. Rani, thank you very much for joining us. And we have Dr. Hani Sabur, who is also one of our physicians at the Heart and Vascular Institute at the Cleveland Clinic in Abu Dhabi. Dr. Sabur holds 2 degrees from the Kuwait University Faculty of Medicine in Basic Medical Sciences and in Medicine and Surgery. And he was twice awarded His Highness the Emir's Gold Medal for Academic Excellence in both degrees. Dr. Sabur has 6 American board certifications and is currently certified by the American Board of Internal Medicine. And he joins us today to, again, do what he loves to do as a teacher. He's been consistently involved in teaching and has been part of the teaching faculty at Brown University since 2006. Dr. Sabur, thank you for joining us. And I now pass it over to your doctors to begin our discussion today.
Well, thank you very much for the introduction. It's really a pleasure to be with my dear friend Ronnie and my partner in crime. I think, Ronnie, do you want to tell us why you started into this pathway?
Yeah, I think that's a great question. So I'm an interventional cardiologist by training. So I do procedures. If the patient's having a heart attack, for example, we would bring them to the cath lab and try to open up the arteries to put in a stent, if necessary, to reestablish blood flow to a heart that was suffering from a heart attack. And I think as part of the training and seeing patients after patient coming into the cath lab, and more dramatically seeing young patients come in with heart attacks and risk factors, or not even realizing that they have certain risk factors that they could have adjusted or eliminated or treated, whether it's with medications or lifestyle. They didn't have the opportunity to make those changes, and then to see them, you know, showing up in the cath lab, showing up with a heart attack, and then having to deal with, you know, what comes with it afterwards. Not that we don't have wonderful treatments for that, but, you know, I think, you know, for me, I looked at it, I mean, our primary goal is really, how do we prevent this from happening in the first place? And so that became a sort of a passion as part of treating patients. Is not only helping them once something has already happened, but really, how do we prevent this from happening in the first place? And so, you know, I actually would put the question back to you also, and kind of, you know, we come from different sort of backgrounds, but we're ending up in the same spot. Is, you know, how do we prevent this from even being an issue in the first place? So I would love to hear from you also, and how you became interested in, especially with, you know, your multiple trainings in different aspects of cardiology, but what led you down this sort of pathway of prevention?
So it's a tremendous insight. Actually, I am myself a type 2 diabetic, and I have a very bad family history. In fact, the reason why I went into cardiology is my dad had his first heart attack when he was in his 40s, when I was an internal medicine resident. And I realized, you know, there's a lot of technology and tremendous advancements that help save lives. So he survived his first heart attack, only to have another one and another one and another one. And the same with, you know, a lot of members of the family. So it struck a chord, exactly as you said. What can we do to prevent this? Why do we not put as much focus on prevention than, in fact, you know, intervention, when in fact we're supposed to be a health service? We should maintain health. And there was a very interesting statement that I heard from the current president of the National Health Service in the UK. We are the National Health Service. We should be promoting health, not just treating disease. So if we take a step back and think about how these patients ultimately develop the heart attack or the heart failure or the arrhythmia, there's a lot that can be done well ahead of the curve. So I think there's some things that would be very helpful to maybe highlight to the audience, that we as practitioners, but also as people who really dedicate a lot of time and effort in preventive cardiology, really the nuts and bolts, how people can completely avoid this problem or avoid it from happening again.
And I think that's, I mean, I really appreciate you being so candid and kind of expressing, you know, partly, you know, some of your family history, because I think that has a very personal aspect to this. And I think part of what we'll realize and we'll express in this talk today is that probably every one of us has some personal aspect and link to cardiovascular disease. We may not realize it. We may not even, you know what that link clearly is. And I think part of our job for today is to really kind of relay that message to the audience, so that people get a better understanding of what it means. And I think even, you know, I was thinking we can even start with what are the traditional risk factors, and then we can kind of maybe march through each one. And of course, if the audience has any questions about them, please put them on the question panel, so we can try to address them as much as possible for today. I think we're not really here to address personal clinical situations. I think that's best addressed in a clinical setting when you're actually one-on-one with your doctor. Whether it's here at Cleveland Clinic Abu Dhabi or your personal doctor. But I think general information and providing educational material is really our goal for today. So, I mean, I'll pass it back to you. I mean, if we were to put that list of risk factors, maybe we can start with that and kind of go from there.
That's an excellent approach. So I think over years, we've realized that there are some big four traditional risk factors. Obviously, smoking is number one, number two, and number three. You know, in the Western world, smoking is declining. There's a lot of laws and there's a lot of disincentives to smoking. Unfortunately, here in the Middle East, we're not quite there yet. There's somehow a recognition of cigarette smoking, but remember, shisha smoking, I think, is basically as detrimental. Now, shisha smoking is culturally very common in the Middle East, particularly among women. And we have direct evidence from clinical studies and from literature that there is absolutely no difference in the risk of shisha smoking versus cigarettes. In fact, people who smoke shisha often smoke for hours at a time, whereas a cigarette, you can really only smoke it for 10 minutes. So I think we have to sort of highlight that awareness. That really fights everything else we do in preventive cardiology. You know, if you're smoking, you're basically preventing all of the benefits that you can do, because it has an impact on obesity, it has an impact on inflammation, on heart attacks and strokes.
I think it's a very important point, is that there's actually there's data to show in 2014, there's a study that showed that the impact of smoking affects 1 in 4 deaths, smoking alone. And now take somebody who maybe also smokes, but also has high cholesterol, or also has diabetes, or also has high blood pressure. These are additive effects that 1 + 1 doesn't equal 2 in these cases. 1 + 1 = 10.
Absolutely.
And other key statistics that some people, some patients sometimes ask, well, can I get away with 1 cigarette a day or 2? They've actually studied this, and even less than 5 cigarettes a day has been shown to have an effect on cardiovascular outcome. And so, when somebody asks me this question, whether it's friend or family or a patient, to me, it's not a negotiable situation. It's a zero policy when it comes to smoking. I don't think you can. It's such an easy risk to eliminate. You just don't make that part of your daily lifestyle.
I think, the other point that we've also seen here in the UAE in particular is that young kids, unfortunately, schools, they have the habit of doing this midwah. This is a very high intensity, low quality tobacco that essentially sort of incinerates, and it's highly addictive. So I think really at that level, having kids addicted to this very intense kind of tobacco smoking really is a very big problem for the individual and for the population as well.
Absolutely. And I think another point to highlight is that secondhand smoke. So if you're in a closed or a close environment, or in a household with somebody else that smokes, your risk is still elevated. It may not be as elevated as somebody who's actually doing the smoking, but do not think that you don't have an elevated risk if a significant other, if a loved one is an active smoker, and you think that you're okay. So even secondhand smoke has its own risk. And I think, there are some statistics that suggest that smoking is actually potentially increasing in the region, and that's a very alarming sign. While, as you said earlier, that Western areas are kind of showing a decline, we're still sort of battling with the smoking. And so, I think it's a no debate type of situation here, that really all forms of smoking should be eliminated.
Not to mention, of course, the impact on cancer. I mean, that's not just that, from cardiovascular disease, but cancer as well.
Yeah.
Now, you mentioned something very important, is that people can have multiple risk factors. The same person can have multiple risk factors, and like you said, they're not additive, they multiply. So one of the things we've sort of noticed here, and this is one of the first things I noticed when I came to the UAE, I came here in 2011. I was called to the emergency room for a 19-year-old with what seemed to be a heart attack. And I had only experienced one time in my whole career in the US somebody that young. And I was almost discounting that. And then the patient we took into the cath lab was another facility. And the LAD, the major artery in the front, was completely blocked. And I was shocked. It basically converted everything that I knew about age and risk factors and everything else. Because in the US, typically a 19-year-old shouldn't have a heart attack. And generally, that's one of the things we use risk calculators to say that it's not likely. But what we found, and it's been very dangerous as a trend, is that we have a uniquely younger population with a lot of cardiovascular disease. So in your experience as an interventional cardiologist, do you see that a lot in the cath lab?
Unfortunately, I do. So, I moved to the United Arab Emirates in 2019, and, single-handedly have seen more patients at a young age having major heart attacks, let alone minor heart attacks, compared to, my majority of my career combined. I mean, it was so alarming that, it's part of why we've sort of taken even a deeper dive in prevention, is because what we're seeing is is dramatic. And, just even looking at our own cath lab here at Cleveland Clinic Abu Dhabi, just looking at the data in the last 3 years, we've actually found that nearly 50% of all of our major heart attacks are occurring in people that are under the age of 50. And actually 1 in 10 are occurring in people under the age of 40. These are dramatic findings that you don't find in majority of the world, except for select areas at high risk. And to kind of, echo what you're saying about additive risk factors, when we actually look, really less than 5% of all of our major heart attacks had no risk factors. So 95% of people had at least one risk factor, if not 2 or 3 or even 4. And so, I think if we're gonna, and I think we're gonna keep coming back to this theme of additive risks. And so if we talked about smoking, and I think we can kind of highlight the next one, and I'll pass it to you to kind of start that off in regards to what is our next risk factor that we're really concerned about.
So I think in context, the big one that's really out there is cholesterol. And there's been some studies here from the UAE with one of our other colleagues, Dr. Wal Hamid, who runs our lipid clinic. We did a registry database back in 2015, 2016, and we found that 1 in 120 patients in the UAE, Emirati nationals, have what is called familial high cholesterol. Very high cholesterol at an early age. It's not really related to diet, not related to weight. And this is extremely alarming because the data from the United States is like 1 in 300 people. And in the UK, it's about 1 in 250. So it's almost double the prevalence. We're not entirely sure why, but it could be due to consanguinity or lack of travel or something like that. But it is a very serious population health hazard. And I think, like Dr. Ronnie just mentioned, in the UAE, 40% of deaths are due to cardiovascular disease. It is literally the #1 cause of death by far, more than anything else. It's fact, higher than car accidents. So clearly it's something that we have to all, as patients, as clinicians, as family members, really pay attention to this. And in fact, the cholesterol is something we can look for. You don't have to look for genetic tests. It's a very simple test. So, what's your approach in a patient like that?
Yeah, I think that's a great question. And we're going to spend, I think we should spend a little bit more time with cholesterol because it is one of those, somewhat contested sometimes by patients. There's different patterns of cholesterol that give us a little bit of information. There's different types of cholesterol. So I think one of the first things really is to get a cholesterol test and look at all the components of a cholesterol test. And when we look at a cholesterol test, you can see what's called the total cholesterol, which really incorporates multiple types of multiple proteins that float around in the blood that carry cholesterol. It also incorporates something called triglycerides, which really kind of look at the amount of different, although cholesterol is sort of a type of fat, triglyceride is a different type of fat, a little bit more traditionally a type of a specific kind that we measure separate than the cholesterol measurement. So that gives us a little bit of piece of information. And the other two aspects of a cholesterol test are what's called the HDL cholesterol and the LDL cholesterol. And the HDL cholesterol is is measuring the amount of cholesterol that the HDL, which is a particle, is a protein that floats around the body. How much cholesterol are these HDL proteins carrying? HDL proteins are considered to be sort of good cholesterol patterns. So seeing that number elevated is usually a good thing for most patients. There are rare genetic types of situations where if that HDL cholesterol is extremely high, that actually might be a bad thing. And this is where having an expert sort of weigh in on that and having a good understanding of what that means. I think the last part of the cholesterol panel is what's called the LDL cholesterol. And these are looking at different types of proteins called low density lipoproteins, that's the L, versus H would be high density lipoprotein. And how much cholesterol are these particles carrying around? And when we see high levels of cholesterol on these particles, this becomes more concerning because these type of particles are more likely to interact with the walls of our artery and bombard the walls of our artery. And in the right setting, for example, in a setting of an inflamed artery or an artery that has an abnormal protective layer, this cholesterol can sort of lodge into the arteries of the wall and start to create plaque. Now, not all plaque means severe blockage, but it means that that body has been able to demonstrate the ability to lodge plaque in the walls. Now, I think one important thing is extremely high cholesterol is one category, and like you said, that's usually genetic, or somebody's born with it, whether they're born with over-absorbing too much cholesterol or over-producing too much cholesterol, the end result becomes similar. And then there's another pattern that's out there called dyslipidemia a little bit, which we start to see more with, folks that may have diabetes or obesity or other sort of metabolic. And so I'll pass that back on to you, because sometimes their LDL is not very high, but the pattern becomes concerning.
So, all cholesterol, as you said very nicely, is not created equal. Our focus right now has been, over the last 20 years, has been on the bad cholesterol, LDL. And it's been very clear now from hundreds of thousands of patients in very well done clinical studies. Almost 400,000 patients were recently analyzed in the big paper from the ACC. There is a direct relationship between high LDL and heart attack and stroke. The higher you go, the more likely you are to have a heart attack and stroke, and it's linear. In fact, they've calculated the ratio. Every 1 millimole, which is 39 milligrams by the old calculation, is equivalent to about a 20% increase in heart attack and stroke over the next 10 years. And if you lower it by the same amount, you get that same 20% reduction. So it becomes almost critical for people who have this number to know what it is as soon as possible, measure it, and then start to tackle it. Now, the group of patients that you just mentioned who are maybe a little bit overweight, and overweight means they may be a little bit diabetic or pre-diabetic, they're not able to get rid of the cholesterol for two reasons. The amount of insulin being secreted and the amount of body fat makes the triglycerides and the cholesterol metabolism slower. So they have slightly higher cholesterol, but the risk is higher because they have other things. They're overweight, they're diabetic and pre-diabetic, they may also have high blood pressure. So these patients have a cluster which is called the Metabolic Syndrome. So this is a very dangerous group of things together. And while some of them may not be very high or very dramatic, having multiple risk factors multiplies the risk of cardiovascular disease. And I think, what you mentioned really is really instructive, because you can have a bad cholesterol of, say, 120, right? Unfortunately, if you look at most lab values, 120 by the old measurements, which is about 2.4 or 2.6 by the new measurements, goes in the lab under almost normal. But and I know that almost every patient who's walked into our cath lab having a heart attack, the average heart attack cholesterol is about 120. So that's not protecting anybody. So those numbers are not real unless you put them in the context of the patient. Absolutely. And their risk. Would you like to elaborate on that?
Yeah, and that really that highlights that the near majority, or a large percentage of patients that do present with a heart attack, their cholesterol may not be highly abnormal. Now, that doesn't change that if you have very high cholesterol, your risk is still higher. But the majority of the population doesn't have very high cholesterol. So we have to be very careful about how we interpret that. But when you pair that with an abnormal cholesterol pattern, so for example, your LDL is slightly higher, but now your HDL is lower than what it should be. And now your triglycerides might be higher than what they should be. That is the dangerous pattern. That is something that needs to be tackled. And then if you pair that with your blood pressure is above normal, even if it's not extremely high, but it's elevated, you've added on some weight as you've become older and specific abdominal weight. This becomes a higher pattern. And then if you start to enter into an area, which we'll dive into, of elevated blood sugars or pre-diabetes or diabetes, then that pattern becomes more dramatic. And I think that this brings up a very important, when we as cardiologists examine patients, the cutoff of what we call normal changes based on the person's risk. So you got to be careful, because a 20-year-old with an LDL of 2.4 might be a pattern that's acceptable, that doesn't need medication, but somebody who has just had their third heart attack and has an LDL of 2.4, that is completely unacceptable. And that is somebody that we need to be aggressive with medications and lifestyle for. And this kind of gets into risk categorization and risk stratification, which we can talk a little bit about. Maybe there are certain calculators that are out there, but also the limitations potentially of them in our region of the world.
Yeah, thank you very much, Ronnie. I think this is exactly the kind of thing that I think people have to be aware of. LDL cholesterol are not just numbers. They do translate into what's called risk. So when we're seeing a patient who has not had a heart attack, we have to take a little bit of a step and do a little bit more analysis of what is your likelihood of, God forbid, having a heart attack or stroke. So in the world, there are many things called risk calculators, and they're derived from long-term studies that showed, the first one was actually called the Framingham study, which is a small town in Massachusetts. And then subsequently, we've had the European scoring systems and the World Health Organization scoring systems. So these are all helpful if you're not having a heart attack, to tell you what's likely to happen. There are some limitations, and most of them are driven by age. So we've had these discussions internally in our group and also in the Emirates Cardiac Society. Most of these calculators basically start calculating your risk above the age of 40. So when we have the younger patients, and as Dr. Ronnie mentioned, there's a lot of patients who've come to our cath lab who are 30 with a heart attack. These calculators don't accurately tell you how much risk, but they can give you an idea. You can get a rough idea, more than normal risk or not. Now, they usually incorporate things like, as I mentioned, age is an important number, the presence of high blood pressure, the presence of cholesterol, and specifically some of them break down by LDL or HDL, different nuances, the presence of diabetes, and of course, male and female sex. The more granular thing that we've been doing now for our higher risk patients is what's called risk enhancers. So while we recognize that some people, maybe the calculator gives you a lower risk, 4%, but you have a terrible family history, or you have had a inflammatory condition like rheumatoid arthritis, or you have a kidney problem. So these are individual clues from your risk assessment. And I think this is something Dr. Ronnie is piloting in his wellness program. If you'd like to just give us some idea of what's personalized risk assessment. Yeah,
part of that is we are establishing a wellness program here at Cleveland Clinic in Abu Dhabi, where we are really sort of targeting that risk to the individual and figuring out what is that individual's personal risk in a sense. And there are, specific, looking at the combination of specific patterns, family history, maybe some sort of testing if it's appropriate in particular situations, that can help us sort of establish not only an overall risk for somebody, but also what is a good treatment plan, what is a good lifestyle plan for somebody, so they can avoid any sort of cardiac event occurring, whether it's a heart attack or even related events such as a stroke or blockage in the legs, these are all sort of related concepts with plaque forming in the walls of our arteries and causing a different event just in a different organ. And I think what you brought up a very important point is that these risk calculators, and some of the limitations of the risk calculators is they don't always assess our population. They don't always assess the population here in the Middle East, because the calculators were really designed and tested against different genetic populations. And as we heard a little bit earlier, the genetics do vary. We know that there are certain populations that are at elevated risk. Some of it may be due to lifestyle, some of it may be due to genetics. And I think science is still trying to figure some of that stuff out. Particular high-risk areas that we are aware of are, of course, South Asians, people from India or Pakistan, and or the Middle East are really at a higher risk group. And so we should really be looking with a microscope at a younger age. And I think there's some data available in regards to, the rates or the risks of having a heart attack when compared to, for example, different areas in the world, so that maybe you can highlight that, there's some studies that were done in the Middle East that give us a little bit of information about that.
Absolutely. So there's actually several robust registries from heart attack centers in the Middle East, basically in the Gulf and the UAE, that have shown not only is as you mentioned, the average age is somewhere in the 40s, which is remarkable because it's about 60 in the US and Western populations, but also that the ethnicity has a significant difference. Middle Eastern and South Asian patients are, regardless of what else you compare, multiplies their risk by about 30 to 40%, which is remarkable considering that they're also younger. And I think one of the controversial issues, I think we should probably open this up now, is what's the problem with treating cholesterol? Why are people still, after 40 years, doubting the need to lower cholesterol and the life-saving benefits of the commonest used treatments, which are statins? I think there's a lot of internet stuff, a lot of fake news, a lot of stuff that's really preventing our patients from seeking the help that they need for that.
Yeah, it's a tough question to answer in regards to why there's so much controversy. I think some of it may just be the way the data was presented earlier on. Understanding the concept of risk when we compare to different risk populations. There may be select individuals where a cholesterol medication may not need to be started right away, but I think making those decisions without an expert, without sort of supplemental information to help you, is where we start to get down a dangerous pattern. And then add that to high-risk populations is where we sort of start to really run into problems. I think the data in regards to cholesterol medications helping to reduce the chance of having a heart attack is not debatable.
Yeah.
I think the question becomes, who's the right person to put the medication on? And if you don't have the knowledge or the data to make that decision, that's where you start to run into trouble. That's where maybe people who don't need to be on a cholesterol medication maybe get put on a cholesterol medication, or worse, people who should be on a cholesterol medication are not started early enough to prevent any sort of prevent any future events from happening. I think we can literally talk about cholesterol for the rest of this event, but I think we should we'll jump to another risk factor. So we've talked about smoking, we talked about cholesterol, we talked a little bit about different risks in different populations. I think another big one to talk about is blood pressure, and such an easily treatable, easily manageable risk factor, and easily detectable risk factor. So maybe what's your sort of opening remarks in regards to blood pressure?
So, there's nothing easier than measuring blood pressure. It's a basic vital sign. Medical students learn to do it. Nurses do it all the time. Automated blood pressure. So there's no shortage of measurement. The main question about blood pressure, this has been known from the 1970s. Every 2 millimeters of mercury blood pressure increases your cardiovascular risk by a measurable constant level. And most people come in with 10 millimeters or 20, higher than normal. And really, if you have a couple of measurements that are abnormal in the clinic, and there's ways to define that, you're putting yourself not only at the risk of heart attack, but also stroke. And that's serious because we have less ability to recover a stroke than a heart attack. And of course, blood pressure not only does that, affects the kidneys as well, which then makes the blood pressure worse and so on. So screening for blood pressure is just something universal. People do it at schools, in colleges, in pharmacies. And I think you cannot ignore this. And if you consider that blood pressure in most people starts to increase after the age of 35, there's not a lot of reasoning behind it. There's not a lot of causes, but again, you have to see a specialist and find out what's going on. Delaying treatment of blood pressure, particularly if you also have high cholesterol and you smoke and you have diabetes, really amplifies your risk almost fourfold. And it's so easy to treat. There is literally nothing easier than maybe losing 5 to 10 kilos when you're early on in the game. Maybe you need a medication. And the medications are so frequent. I mean, we have at least 5 or 6 different categories of medication in whom the side effects are very low, and they really have a lot of benefit, not just to treat the number, but to prevent serious events that we can really completely eliminate, if you think about it. And the WHO has actually stated this as one of the WHO best buys for all countries, regardless of socioeconomic status. Treatment of blood pressure is a very high priority project. And some of it is, diet, lifestyle, and other things, but of course, following up and getting a number.
I think you said it perfectly. I think the world does a reasonable job at screening for high blood pressure. I think the problem becomes treating. I've definitely seen a relatively large share of patients who come in with clear high blood pressure. I mean, no debate. High blood pressure in the 150s. The top number in the 150s, maybe the bottom number is in the high 90s, maybe even in the hundreds. And they're still not on the blood pressure medication. And worse, they've seen multiple doctors. And I think a common thing is delaying the treatment, and that's delaying time for care. And the other big thing that you mentioned is that we're not just talking, even though this is a heart-focused presentation, high blood pressure has an impact on the whole body, and it can cause the kidneys to fail, leading to the need to be on dialysis, which completely changes everything for the person who has to end up with either bad kidneys or even worse, ending up to the point where they need dialysis. Stroke, which what you said, we can't manage strokes as well, or treatment options are more limited. And so I think the key thing is really, when do you make the decision to treat, and how do we make a decision to treat? And again, similar to cholesterol, we have different cutoffs, but there are sort of established cutoffs that are really considered high. I mean, I think if your blood pressure is above 140 on the top number, there's essentially no debate. That needs to come down. The question becomes, how do we bring it down? Now, you take a young patient who's otherwise relatively healthy, doesn't have some of these other risk factors that we're talking about. We want to do a trial of 3 months to truly change lifestyle. And I think that's the key thing. I mean, if the patient is not going to change their lifestyle, or they're unable to, which I would argue there's no excuse, then you really should talk about whether or not medications need to be started sooner than later, And I think, patients have a reluctance. A lot of times they'll say, oh, give me another 3 months, give me another 3 months, give me another 3 months. And then they maybe see another doctor, and now 2 years have gone by, and each doctor is giving another 3 months, and we've lost a lot of time. I've definitely had patients make remarkable improvements with their blood pressure by dropping weight, by establishing exercise and making that as part of their healthy habits, cutting down on, salt and, processed foods. And we can get into food. We can spend a whole conversation about the healthy foods, but in general, shifting their food habits to whole, unprocessed foods, mostly around, I would say, fruits and vegetables, with the added protein that's appropriate. And that, again, is its own discussion. And then when that doesn't work, really there are phenomenal and safe medications when it comes to blood pressure. And so I don't think there's, it's one of the easiest things to measure. I mean, you can even buy your own blood pressure machine, or get it and have it at home, and follow your own blood pressure to see if you're seeing changes.
I think we have less resistance to treating blood pressure because people, I think, have made that link a long time ago. And it's something that some people unfortunately have symptoms. They have headache. That's rare though. And I think we don't want to leave people, as you said, 3 months and then 3 months and 3 months. This is, clearly in the international guidelines, the trial is for 3 months. After that, you have to make a decision, because really those 3 months will make a difference in terms of heart attack.
Absolutely.
The clock's running out.
Yeah, absolutely. And so, I mean, there's data to show that even though, some older guidelines use 140 as a cutoff, newer guidelines are probably moving towards 120 as the cutoff. of when we really need to start treatment. And that's sort of what I use. I mean, if I see the blood pressure hovering above 120, the conversation needs to start, you know, and then the decision about medications comes with the individual patient. Going back to what we keep, you know, bringing up again and again, is that you need to make decisions with the patient in front of you and put together what are all the risk factors in that patient. And so, you know, should we move to another risk factor? What would you kind of say is another kind of key risk factor?
Yeah, I think the issue of the link between obesity, diabetes, and what's called metabolic syndrome is very big. In the UAE, there are 1 million diabetic people. That's 1 in 9 people are diabetic. And it's projected if the current status of, you know, being overweight and so on continues, by 2030, we're going to have 3 million people who have either some form of diabetes or prediabetes. And that translates into a tremendous amount of heart disease. Now, the link between diabetes and heart disease has been recently more clear because of some clinical studies and some investigations, basically over the last 10 years. And this link is remarkably powerful. You know, people with diabetes lose about 12 years of their projected lifespan, 12 years. So that means they die 12 years younger, have heart attacks twice as many, and they also have the added problem of kidney disease, because the diabetes doesn't just affect the blood vessels, it affects your eyes, affects your kidneys, causes vascular problems and amputation. So diabetes is kind of like a silent cancer, but it's very prevalent. And unfortunately, our approach to it has been relatively limited. We don't really look at it unless the patient has a high blood sugar. And what's being recommended now in all the literature and the guidelines is we take a step before that. If you are overweight, the central obesity, the central fat is very unhealthy fat. It basically causes the body to produce enormous amounts of insulin, causes a lot of inflammation, which also is associated with more cholesterol, more triglycerides, and elevates the blood pressure. So it's going to lead to the entire triple threat we're also afraid of from the beginning in the same person. And this is a really serious thing. And I think you can recognize this when a patient comes into the clinic. One, we know that their weight is above their target. So we have something called the body mass index, which is the weight height, but also we look at the waist circumference. You can tell from your pant size, actually, if you have this abdominal visceral obesity. So that's just a visual. That doesn't even need a blood test. Mm-hmm. And in fact, the Emirates Diabetes Society, along with the Emirates Cardiovascular Society, have come up with a new program for assessing this problem by testing your sugar or your A1C at the age of 35, because it is just so common in the Middle East. And we can go back to the discussion of how you treat this problem, but the presence of this problem amplifies your risk of heart attack and stroke tremendously. The good news is we have a lot of fundamental ways to treat this, from medical interventions, physical interventions, lifestyle and functional medicine and nutritional medicine, as well as very specific treatments that can prevent the diabetes from becoming overwhelming, prevent the patient from becoming diabetic in the first place, and if they have diabetes, not to get that terrible complication.
I think one of the fundamental things that you said is that there's a clear link with diabetes and cardiovascular problems. And, maybe that wasn't so clear in, 5 to 10 years ago, not necessarily because the information wasn't there, but that message wasn't as clear, where that link is very well established. And so, even looking at our patients that have had major heart attacks, nearly 50% of all of our patients that presented had diabetes. And linking diabetes to being overweight, nearly 70% of the patients that presented with heart attack were overweight or obese. And the other part of this is that what do we define as overweight? And I think sometimes we think that you need to have an extreme amount of extra weight on board to be considered to be overweight. And that's a misunderstanding. Really, when we talk about weight, I think the key thing and what Dr. Hani and I are really trying to focus on is really that extra weight that forms here as we get older. And I sort of tell sometimes patients is, your goal is to be what your weight was when you're 18 or 21 or something when you were in your teenage years. And while we can't necessarily, it's hard to obtain that, but that's really where we're talking about before we start to see those metabolic changes. And there's actually data on this, that there's less wiggle room, so the amount of weight that somebody who's from the Middle East or somebody who's, for example, South Asian background, that they need to gain before you start to see these metabolic problems, changes in cholesterol, blood pressure going up, your blood sugars going up, is less than when compared to other genetic populations. And so again, just kind of re-emphasizing that risk starts earlier with less changes. And you don't need to be severely overweight to develop diabetes. That's also kind of a misunderstanding. Even though they're linked, it's not one-to-one.
Exactly.
What are other sort of risk factors, just to even at least even if we list them for the sake of time, that we would, I think we really mentioned the main major ones, but other risk factors that just people should be aware of.
So having a family history is important.
Absolutely.
So if you've had a male family member less than 55 with a heart attack, and maybe we can adjust it here in the Middle East, because obviously that number encompasses almost all of our patients, or especially a female less than 65, that's important. Women who've had hypertension complications during pregnancy, like preeclampsia, women with polycystic ovary syndrome, people with long-standing history of high triglycerides, rheumatoid arthritis. So these are all additional factors. There's some other things that we would do in the clinic for more precise measurement, looking at some special markers like CRP, lipoprotein A. These are not things that are usually done in general practice, but in our practice, because we're really looking to be prevention focused. And sometimes we do a special test, like the calcium score,
right?
Which is really a very simple scan. It's more of an X-ray than anything with IV, and gives you a really immediate snapshot. If you have calcium in your arteries, you already had hardening of the arteries. And if that's happening when you're 30 or 40, that's a big problem. And that really tells us that we've already started this triggered process of atherosclerosis, which we need to sort of work on in a more aggressive, comprehensive manner. And, of course, diabetes, we mentioned that, pre-diabetes, kidney disease as well. And, there's many other things that you can do to more precisely map your risk in an individual in order to make decisions on long-term treatment.
I think that there's the other two that I would add that are risk factors, but are also the lack of. So, maintaining a healthy eating habit throughout your lifetime, and making sure that exercise is part of your, routine lifestyle, and really trying to maintain a certain amount of exercise throughout. And so I think for the sake of time, we'll open up to some questions. Sure. And address some questions that may be from the audience.
Fantastic, Dr. Ronnie and Dr. Hani. This was brilliant for all of us, but for me especially, this was very helpful. Some of the questions we've received today, it was fantastic to be able to learn what the risk factors are. How would a person who is, thinking themselves to be healthy, so somebody that may not have some of the risk factors that you've talked about, know that, what are the signs of an unhealthy heart? What symptoms may go unnoticed? And that would be a sign for somebody to go get checked.
So what we were talking about earlier is mostly people who don't have symptoms, but thank you for bringing that up, because unfortunately some cardiac symptoms are not very clear. So sometimes we've had patients we've received with a heart attack who have symptoms like heartburn. They think it's heartburn. They think it's like just acid reflux, and they're taking, some antacids or something like that. The problem is if you find these symptoms in relationship to movement and effort and exertion, and they come with other things like sweating or feeling nauseous or going into your back or neck or chest. In general, if you have symptoms like that, you really need to go to the first emergency room, get in really quickly and get checked out, because those things cannot be properly diagnosed without the presence of an ECG and some blood tests and so on. So unfortunately, these late presentations can be really devastating, because it makes it much more difficult to get the artery open. Any other kind of symptoms, Ronnie, that you want to?
Sometimes diabetics don't present with the classical pain or discomfort. I think also we have a little bit of a misunderstanding. Sometimes we use the word pain, but sometimes, actually majority of the time, patients who are having a heart attack, it may not be, quote, painful, but it may be a pressure sensation that they're feeling, or they may just feel out of breath significantly out of breath, or having trouble, taking deep breaths in, or they may feel it sometimes, discomfort in the arm or the jaw area that would present. This is sort of what we worry about when we're worried about a heart attack. Sometimes it's not something that happens suddenly or while they're sitting. They may not have anything while they're sitting, but let's say they decide to run, or they run on a treadmill, they go up 3 or 4 flights of stairs, and now they're getting a discomfort in their chest that's making them have to stop for a few minutes before they continue. That may not necessarily be a heart attack, but that may be a sign that there's a blockage in one of the arteries that's limiting blood flow, that may not be giving them a problem when they're sitting, but then when they try to do something, when the heart is asking for more blood, it's unable to receive the extra flow because of a blockage that may have formed gradually over time and not suddenly like a heart attack. And just kind of a small point, it's a big point, is that females may not present sometimes, and they sometimes present in more atypical fashion. They may not present with a sort of classic chest pressure on the chest that you put your hand and then you're feeling a chest. So, that's where getting to the emergency room and getting evaluated to get that, make sure that that's not what's happening before we look into other things that, that could be related to that, whether it's the lung or the stomach or the esophagus. But before we jump to that, we want to make sure that nothing's happening with the heart.
Exactly.
Sure. And now we have a bit of a topical question. When it comes to the heart health and the COVID vaccine, if somebody has had a heart valve replacement, would that person be able to take the Pfizer vaccine, particularly as we're now being asked to take boosters and the people may have already taken Sinopharm?
So let me just pitch in on this one. So the data from the World Health Organization, CDC, and the Abu Dhabi Department of Health is very clear. People who are not vaccinated are at multiple fold of risk of getting COVID. And it is the sickest people we have in the ICU now who are not vaccinated. The Pfizer vaccine in particular has now been fully approved by the FDA. And really, we're actually giving it to children above the age of 12 and even pregnant women. It is incredibly safe. And the side effects you get from it are very small. I mean, in the general population, we're talking about fever, something that goes away with paracetamol, and the risk is very low. The risk of not being vaccinated is much higher. In fact, we also know that people who are cardiovascular disease, diabetes, prior heart attack, AFib, strokes, are at much higher risk of getting a really serious COVID infection. And we actually recommend to all of our patients, when they come to the clinic, first question, have you had your vaccine? Yes, you need to get your vaccine. So I think on behalf of public health in this current pandemic, I think all cardiac patients and all lung patients and all kidney patients really need to get themselves vaccinated. Ronnie, any ideas on that?
No, I think you said it perfectly. I think just to double down on what you're saying is that if you have cardiac conditions, you are at an elevated risk of major complications if you get COVID. And that is one of the fundamental reasons to get vaccinated. And vaccines are, like you said, incredibly safe. And the risk from the vaccine is very low when compared to the risk of complications if one was to get COVID.
And of course, not to forget the influenza vaccine, because that season's coming too.
Okay. And in the interest of time, we'll take a last question. Talking about shisha, I know we've touched on it earlier, and we had talked about shisha being, no matter what it is damaging. And you'd mentioned that there was some research around it. There's a lot of talk around shisha, some saying it's as bad as 200 cigarettes and some saying it's not so much. Could you shed a little bit more light on the kind of data and the insights that we have around shisha?
So actually, one of our colleagues in the UAE, Dr. Ldl Cholesterol, actually published data from a cohort of shisha smokers. And he measured the amount of carbon monoxide, nicotine, in 100 people smoking shisha. And they just left them to smoke whatever they normally did versus cigarettes. It is significantly higher. Now, I don't know if it's 200 or 300, but the amount is higher because remember, the bubbler is not actually a filter. It's just cooling the air. It's not actually dissolving. People think this, it's not true at all. It's not dissolving any of the tar or nicotine because that's the gas that's coming into your lungs. You're actually still inhaling a gas that contains a lot of toxins, right? And the duration of smoking, because it's a social event, is hours. Most people sit in the cafe or even at home and they smoke for hours. They're continuously inhaling. And because it is humidified, they're able to tolerate more inhalation and they inhale more deeply. So the reality is you're getting a lot of the toxicity. It's simply humidified. And now they have these flavored shishas, which makes it even more attractive. So I think the social aspect of it makes it more dangerous because unfortunately it's still socially acceptable to do so. And if you go anywhere in New York, right, you can't be seen anywhere and you're not even allowed to smoke in public, private, in your apartment. It's unbelievable. But I think that's what it takes is a concerted regulatory social effort to get off the smoking. Tobacco is bad. Tobacco is never going to be okay in any cardiovascular, renal, cancer unit. There's absolutely no reason. It's just a highly addictive drug that is unfortunately causing a lot of toxicity over a lot of years over many people, especially young people.
Absolutely, and it's so easy to sit and you're smoking shisha and doing it for such a long time, or you're not smoking the shisha, but you're sitting with your friends and you're hanging out and you're just inhaling secondhand smoke for hours or minutes and at a time and thinking, well, I'm not actually participating. Well, maybe there's some benefit, but there's clear still associated risk that is higher.
Absolutely.
Well, Dr. Rani and Dr. Hani, thank you so much for your time today. To our audience, if you didn't have the chance to get your question answered, but if you or a loved one are worried about heart disease, please make sure you reach out to us on the screen. You have a number that you can reach out to us on, and you can also visit hearthealth.clevelandclinicabudhabi.ae. Thank you everybody for joining us today. Thank you, Dr. Rani and Dr. Hani once again, and I wish you all a very pleasant evening.
Thank you. Thank you.